Fainting. Most people think it's just a minor dizzy spell, but in the world of EMS, syncope, the medical term for fainting, is a high-stakes puzzle. It's a sudden temporary loss of consciousness followed by a near instant recovery. Today, we're going to break down the why, the how, and what you need to do when your patient hits the floor. So the why, think of your brain like a high-end computer. It requires a constant, steady stream of power to stay on. The power comes from blood flow, specifically oxygen and glucose. The pathophysiology of syncope is simple. It's a brief interruption in cerebral perfusion. For just a few seconds, the brain's blood pressure drops, the power cuts off, and the patient goes down. Because they are now horizontal, gravity stops fighting the heart, blood flow returns to the head, and they wake up. Common triggers include a glitch in the nervous system, like a vasovagal response, or more serious issues like a sudden cardiac arrhythmia or a drop in blood volume. Syncope usually doesn't happen without warning. This is called the prodromal phase. Your patient might report lightheadedness or graying out of their vision, nausea or sudden cold sweat, a feeling of pounding in the chest. During the event, they will be unresponsive with a loss of muscle tone. Unlike a seizure, there is typically no aura and the recovery is fast. Within a minute, they should be back to their baseline. If they remain confused for a long time, you aren't looking at syncope. You're looking at a post-ictal state from a seizure. How to? When you arrive, your first goal is to rule out the killers, A, B, C's. So ensure the airway is clear. If they fail, do they hit their head? Consider C-spine. The EKG, syncope can be the only warning sign of a lethal arrhythmia. If you're an EMT, get ALS moving for a 12 lead. Bottles and glucose, always check a blood sugar. Hypoglycemia can look exactly like syncope. Orthostatic vital signs, if the patient is stable, check their BP while lying, sitting, and standing. A big drop suggests dehydration or internal bleeding. So the treatment is focused on support. Keep them supine to maximize blood flow to the brain. Administer oxygen if their saturation is below 94%. Most importantly, every syncope patient needs to be transported. Even if they feel fine now, we need a hospital to prove their heart isn't about to stop. So in conclusion, syncope is the brain's way of hitting the reset button. Your job is to make sure that when it turns back on, the system is stable.